and good morning, everyone. I'm just making sure that I'm connected to all of our platforms here. I think that Facebook is just loading. Okay, I think we are connected. So, hello and good morning, everyone, and welcome. Hi, welcome to the PT on Ice Daily Show. My name is Kelsey Valentine, and I am one of the two faculty for clinical management of the fitness athlete, pregnancy and postpartum. And I'm also a pelvic floor physiotherapist. Hi, Christina and I teach an 8-week online course that focuses on taking some of the fear out of working with your pregnant and postpartum patients that want to continue to train and be fit during this phase of their life, even if you aren't a pelvic health physiotherapist. So our next cohort is starting in September, on September 14th. So if you'd like to join us, then you can go ahead and head on over to ptonice.com/our-courses. And you can sign up there. So we hope to see you. So today I'm going to be talking all about the conservative management of Diastasis rectus abdominis. So what I'd like to do is just kind of go over some general information about it. And then I want to take you guys through a little bit of a mock case study or something along those lines that you can use clinically that can help you kind of go into an assessment if you have an assessment for DRA today. So we'll start by just defining diastasis recti. Essentially, it's just a widening of the linea alba, so that tissue between our rectus abdominis muscles that causes a separation between those rectus muscles beyond what we consider to be the normal distance. And that normal distance kind of varies based on where you're reading in the literature. But clinically, we kind of define that as about 2 finger widths of a gap between those rectus muscles. When I discuss this with my clients, I use a little bit of different terminology because some of the wording around it can be really fearful. So if you hear ab separation, or the client hears ab separation, they become really fearful and they worry that, you know, if they move the wrong way or if they do something wrong, that their abs are going to split apart or they're going to tear apart, which we know is not true. So I tend to use more of a language that's a little bit less intimidating with my clients. So I might say a widening of your tissue between the six-pack muscles. And I explain to them that it's very normal to happen during pregnancy and that it might continue after your baby's born, and that's okay. And there's a lot of things that we can do to kind of manage that. So although diastasis recti can be found at any stage of life with any sex, we tend to see it most commonly during pregnancy and postpartum. So during pregnancy, we know it's incredibly normal and common, and that's okay to have. So we see about 100% of people who are at the end of their pregnancy in that late 3rd trimester, they all seem to have some form of diastasis recti. And it's normal because our abdominal muscles have to widen in order to make room for our growing uterus. So we tend not to be too concerned about it during this phase, but it doesn't mean that there still aren't some things that we can do to kind of manage some of that intra-abdominal pressure during pregnancy as well. Postpartum, the numbers kind of taper off as we get further along postpartum. So research tells us around 60% of people experience DRA at 6 weeks postpartum, and that tapers down to about 45% at 6 months postpartum, and around 32% at a year postpartum. So it continues to be incredibly common, and it's definitely something that a lot of our patients have concerns about whether they're expressing it to us or not. There's still a lot of information that we don't have about diastasis recti. The literature is really severely lacking in this area. So there's no real consensus about what makes us more at risk for developing DRA, but there have been some proposed factors. So some that have been suggested are being an older age when you give birth. So whether that's because our connective tissue just isn't as pliable as we age, that could be the reason. If you have had more children, you may be at a higher risk of developing DRA, just more times where you've been stretched out to max capacity with pregnancy. A cesarean section might make us more likely to develop a DRA, and that just could be because of the lack of tissue mobility at the bottom end of our core. Excessive weight gain might make us at a higher risk, and we even see this sometimes in, you might see this in your male clients as well. So if there's been a kind of a rapid period of weight gain where that tissue gets stretched, then that can be a risk factor for DRA. If the baby is a higher birth weight, then that can make us more likely to develop it potentially. Again, just because our tissue is getting stretched even further with a bigger baby. And for that same reason, carrying multiples. So if you're pregnant with twins or triplets or more, then that can make us at a higher risk. And they've also proposed that childcare can be a risk factor for developing DRA. So potentially if you don't have help with some of those daily activities, you're doing a lot of heavy lifting and not managing your loads appropriately would be my guess. But I'm not too sure why that one's considered a risk factor. We also really don't have a lot of concrete evidence on what some of the consequences of having a diastasis recti are. So predominantly, I find the clients that come into my clinic are concerned about mostly the cosmetic aspect of the DRA. So they tend to complain that they look still pregnant even after they've had their baby, even after years after they've had their baby. They call it, the mummy tummy. There's a lot of not nice language around something that's so natural that does happen. So generally I find my clients are more concerned about the appearance of it than the actual function or associated factors. In today's society, I know that we're so concerned about, looking like we never had a baby, bouncing back, having that flat tummy. So it's unfortunate, but it's kind of our reality, and it is still important to discuss these factors with our clients because we know how much physical appearance can relate to our psychosocial side of things. So I actually saw a study just this morning that said that people who were dissatisfied with their physical appearance were more likely to develop postpartum depression. So although it is cosmetic, it's still very relevant to both their physical, mental, emotional health as well. But some of the non-cosmetic consequences that have been proposed but are yet to be shown as causative factors would be things like low back pain or pelvic pain, decreased stability of those joints in our low back and our pelvis, as well as pelvic floor dysfunction like incontinence and prolapse. But again, not totally confirmed in the research that these are causative factors, but there has been an association between pain and diastasis or pelvic floor dysfunction and diastasis. I think that probably one of the biggest problems about diastasis recti with our clients is that there is so much misinformation out there about it. Unfortunately, during this time, women are really vulnerable. They're kind of desperate for anything that can help them feel like they did before they were pregnant. And so they get preyed upon a lot by, marketing strategies and things that are promising that quick fix to their diastasis recti. So I've seen things like belly wraps and belly binders that promise the diastasis to disappear, creams, cleanses, and even fitness programs that aren't necessarily evidence-based or just kind of promote all of the unsafe exercises that should be avoided. And that can be incredibly harmful for our patients as well. So I gathered some quotes from some of the top hits when I looked online about diastasis recti because I wanted to see what our clients potentially would be seeing when they first hear that they have a diastasis recti. Of course, the first thing we do is go to Dr. Google to see what we can do about it. So when we go to Dr. Google, the first thing that comes up is an article from parents.com, and I kind of skimmed through that. And something that stood out to me was a quote that said that they should be avoiding exercises that can exacerbate the problem, such as crunches, a major diastasis recti no-no. So That's incredibly terrifying for our patients to hear that that's a major no-no, and they should never do it, especially if they've already been doing some of these things. The other one that I was really, really disappointed in was I went to webmd.com because, whoops, lost my camera here, because I know that a lot of us go to webmd.com probably if we hear of any other medical issues that we have. So I know that our patients are going there to see what they can do about their medical issues. And this one was really disappointing. So webmd.com said, do be careful with exercise. Some routine fitness moves, including crunches, sit-ups, push-ups, press-ups, and front planks, make abdominal separation worse. So can swimming, some yoga poses like downward dog, and doing anything on your hands and knees. Some trainers may suggest those exercises for women with abdominal separation, not knowing what could happen. So you can imagine that reading that, you would be scared to do absolutely anything. And this is from webmd.com, so it's a pretty trusted source for a lot of people. So a lot of these things, we just have to do in our regular life. They can't necessarily be avoided. Swimming, like people love to swim. What's wrong with swimming? Being on your hands and knees should be avoided at all costs. I just think that that's going to be so terrifying for our patients to read, and it will leave them feeling incredibly hopeless. It will make them feel like they can't move, they can't do anything safely without their abdominal muscles potentially separating or rupturing, and that's so scary for them. So I know a lot in the medical world we talk about first doing no harm to our patients, but I would argue that giving them this long list of exercises that they can't do that are unsafe is way more harmful than what they could be doing in terms of exercise. So the benefits to me of exercise outweigh the risks of the potential abdominal separation that can happen, full stop. And I think our patients need to know that. But not only that, but this information that they're getting is not evidence-based, and that we need to really change the messaging that's considered commonplace around diastasis recti, and we play a huge role in doing that. But right now we don't even have, again, enough evidence to kind of show any sort of causative relationship between some of those things that are making us fearmonger movement, like doming or coning at the midline. So a lot of what people are told is that this doming and coning that happens when they go to sit up out of bed can cause the abdominal separation or a widening of the gap. But there isn't really any causative evidence to my knowledge that actually shows a relationship between those two things. So suggesting to our clients to avoid certain exercises and instill fear is not only potentially harmful for their physical and mental health, but it's also not evidence-based. But on the same breath, we don't have evidence to suggest that there isn't a relationship there either. So that's why my approach usually involves kind of a progressive and graduated core strengthening regime, so that the load that the patient is being given does not exceed the load that they can manage. So the way I like to conceptualize doming or coning that can happen when we crunch or sit up or do a plank or all of those things that we should avoid, I like to think of that doming as just a symptom. So in our patients with pain, we don't tell them to just power through all of the pain and completely ignore the pain, but we also don't tell them to totally avoid that pain and relax on the couch and do nothing. So I like to think of doming as information. It's just information about what's happening inside of our abdomen and how the muscles and our tissues are responding to it. Often, once given some strategies, I find that my clients have a really easy time at learning to manage that intra-abdominal pressure, so decrease the amount of doming or coning that they have and still do all of the exercises that they love to do without the symptoms that may or may not be causing that DRA or making it worse. So if we consider that doming, coning, tenting, whatever you want to call it, to be just a symptom, then we just use it as feedback to assess our ability to control it. Just as if that symptom was pain, we use pain all the time in our practice as feedback about kind of how our patient is tolerating a load and how to respond to that and change the load that we're giving them. So what I want to do is kind of take you through a brief mock assessment. We don't have lots of time to do a big one, of a client with DRA. So there was a study by Keel and colleagues that tells us that PTs aren't on the same page about how to manage DRA. So we have all sorts of PTs using things like modalities and taping techniques and manual therapy. Again, that's not really evidence-based. It's not overly supported in the literature. And, um, and if we had a client that came in with weak tissue anywhere else, I really don't think we'd be using those strategies too much. So we know that we need to load the tissue, but even within that loading, there's still a lot of um, not agreement about how to load the tissue appropriately. So I think that we tend to really underdose our clients with DRA. We tend to just give them TA contractions and supine or pelvic tilts or single leg raises, and that's barely loading that tissue. So I think that there's so much more that we can do, and I hope to kind of show you that when I take you through this kind of brief mock assessment. So you have a patient today that comes into your clinic with diastasis recti, and that's their primary concern that they're coming in with. So during that subjective assessment, I'm sure you guys all do this already, but I really want you to listen to their whole story. Don't interrupt them. Just listen and see kind of why they're concerned about this DRA. Is it that they're concerned that they can't do what they used to be able to do? Maybe they're usually a CrossFit athlete and they're not able to do those things that they enjoy anymore. Is it that they're concerned that their abs will rip apart when they go to move? Is it that they're concerned about the cosmetic aspect? And then if they're not talking about those things in the assessment, then you can do some follow-up questions after you listen. But try and gather as much just by listening to their story first. So you might want to follow up with questions like what their beliefs are about DRA, or what they've been told in the past by other healthcare practitioners, what they've read online, and again, what those fears are that they have or their specific concerns. If they're not concerned about it, they're not coming into physio. So they definitely have some fears, and sometimes we have to really tease that out of them. I want to reiterate that if their concerns are predominantly cosmetic and they're worried just about the appearance of that tummy, don't be judgmental about that. Don't think of it as something that we don't treat, because the second that they feel that judgment, they lose our trust. They're probably going to stop coming to see us, and then those cosmetic concerns don't go away, and they're probably just going to use some really less evidence-based strategies to try and improve their DRA. So we are in the perfect place to help. Even though it's a cosmetic concern, we are in the perfect position to help them. And like I said before, those cosmetic concerns can translate into physical health concerns, mental health concerns, if they aren't loading the tissue appropriately. So definitely listen to those cosmetic concerns. Do not brush them off. And know that you could be the difference between an unnecessary tummy tuck surgery, or if it's a really severe diastasis and they're desperate to have that surgery, you could be the person who helps them load that tissue appropriately, get them really strong going into surgery, and then see them again afterwards, and again rehab them post-op as well. So that subjective history is so important, even in diastasis recti. I think the objective assessment is kind of where we tend to see a lot of different things with our assessment. So usually I'll just start my assessment with some observation. So I'll look at the tissue itself. I look for signs that the tissue has been overstretched. So you might find some striations in the tissue, or it might look like a balloon that's kind of been overstretched. You're going to look to see or ask if they are pregnant, if they are having any kind of postural issues that's putting more strain on that linea alba. You're going to look for signs of ab gripping. So are they really tensing through their upper abdominals or trying to suck everything in all the time and not kind of breathing through their abdominal wall? You're going to observe their diaphragm breathing. Are they chest breathing or ab gripping through their breathing, or are they breathing nicely through that rib cage and through that lower abdomen as well? So that's kind of what I'm looking for from an observation perspective. And I want to take you guys through a proper diastasis recti assessment as well. So hopefully some of you guys are tuning into the video, but for those of you who are just listening to the podcast, I'll try and describe this as best I can. So I'm just going to kind of tilt you guys down so you can see me a little bit better, because I'll be doing this from the floor. Let's see here. Okay. Okay, so for our objective assessment, again, I'm going through this really quickly, but hopefully it will give you guys a bit more information. So we're going to start by just having them in a crook-lying position, having their belly totally relaxed. What a lot of people want to do when you touch their belly is kind of grip or tense because they don't want you to feel the flabbiness or whatever their concern is. But make sure that their tummy is totally relaxed. You're going to start by feeling down that linea alba. So what I'm feeling for is not only any separation, but also we're feeling for the integrity of that linea alba. So what their tissue tension is like. So I'm starting at the sternum, feeling down. What you should feel is some springiness to the tissue. So it should feel kind of like a bouncy trampoline. You might find in certain areas, it tends to be more common around the umbilicus, that the tissue becomes a bit more soft or squishy. You might feel like you can sink your fingers deep down. And at that point, when you find a spot like that, you can measure the width of the gap with the number of fingers that you have, as well as kind of the tissue tension, how far your fingers can sink down into that tissue. So in some of my clients, you might even need a second hand, and you're kind of feeling that tissue integrity. Generally, yeah, again, around the umbilicus is usually where it's the most weak, but you can continue to feel all the way down to the pubic bone as well. And again, feeling for springiness and the width of that gap. When you find a spot that has lower integrity of strength, you're going to stay there, and then you're going to have your client lift their head and shoulders up off of the examination table. So what you're feeling for is when they lift their head and shoulders up, are you feeling some good tension of the linea alba develop? Or do you feel like your fingers can just sink right down, right into their, basically it feels like your hands are going right into their guts. And you're feeling if you can feel the rectus muscles kind of approximate around your fingers. So when I do that, I usually actually get my clients to feel for themselves as well. Some of them get really weirded out or grossed out by this, but I get them to feel themselves and see if they can feel those rectus muscles come around their fingers. What I then usually do is get them to activate that TA muscle. So I'll use some cues that have them kind of just brace their abdominal wall, and then I'll get them to put their fingers there, or I will put my fingers there, and then I repeat that head lift and lift the head and the shoulder blades up off the plinth and back down. And then I'm seeing, is there good tissue tension when they can contract their TA muscle, or do they feel like they can't contract it, or does it continue to just sink down with that? From there, I'll kind of use whatever other strategies I can think of that might activate other abdominal muscles to see if some other muscles might help to decrease the amount of sinking in that I'm feeling, or improve the tension of the linea alba that I'm getting. So sometimes I might play around with other things like I might get them to resist shoulder flexion to try and activate those internal and external obliques. Or I might get them to try a different breathing strategy, use some different cues for transversus, etc., to see if I can do anything that helps to improve some of that tissue integrity when we do the crunch. So then after that, I want to do this also in multiple positions. So it's one thing to see it in supine, but I also want to look at this in quadruped position, in side lying, in standing, during an exercise that they enjoy doing, and just getting a full picture of what how their core looks in multiple different positions or in different functional activities that they might do. So I basically repeat the same thing. After that, I'll look for signs of doming in activities that they enjoy. So maybe they love doing pull-ups on the bar. I might look and see if there's any doming there, or I might feel to see if there's any reduced tension at the midline. Maybe it improves, and that's great. I'll then kind of do some muscle strength tests for a lot of the different core muscles. So internal and external obliques. I'll look at the transversus multifidi, the rectus muscles. I'll look at them in a plank and see how long they can hold that for. I'll look at the erectors. If you're a pelvic floor PT, you can look at the pelvic floor, diaphragm function and their breathing, etc. And then I'll move into, from there, seeing if there's a way that we can reduce the doming. So if you can find an activity that causes that doming, typically it might be something like a crunch, then I'm looking for something that can reduce that. So oftentimes all it takes is a simple transversus abdominis contraction that will reduce the doming and will allow them to do their activity again. But for some people, and it will allow them to kind of spread that load across their abdominal wall. In other people, like I said, sometimes I'll get them to resist shoulder flexion to get those obliques firing. But you can get really creative here and know that each patient is unique. And so they might not get doming on a crunch, but they might get it during a pull-up. So you can look at them doing a pull-up and get kind of creative about how to spread that abdominal load or get some more tissue tension and reduce the doming there. So that was kind of just, a really brief overview. We're going over time here. From there, I just get into exercise prescription. So based on what I found in my assessment, I'm going to give some targeted exercises. Not everyone should be lying in supine and practicing TA activation. It needs to be functional. However, in some cases, more of an isometric core exercise may be all that they can manage without getting that doming or coning. And so if this is the case, then we just need to make it a bit more functional for them. So maybe if they can perform a TA activation and that reduces their doming or coning, but as soon as they try and do it with a crunch or a higher level core exercise, it might reproduce the doming or coning. So I might just get them to practice that TA activation in functional positions or doing daily activities of daily living, etc., just to make sure that it continues to fire. If I have a patient that struggles to find anything that reduces the doming or coning, then it depends. I might send them home with working on just getting that core moving, so getting some abdominal diaphragmatic breathing going, working on that in some more functional positions, and getting them doing just any other core exercise or any other exercise that doesn't exacerbate their symptoms, just to get them moving and show them that it's safe to move. So maybe something like a side plank or an elevated plank or a kettlebell side bend, or even non-specific exercises like squats, deadlifts, anything that can just keep them moving and show them that exercise is safe for them. And then in some people, I'm giving them really high level exercise because maybe we have found a strategy that reduces their doming or coning, and then they can do just about anything. So I say the sky is the limit, and we really want to not underdose these people and progressively load their tissue. So give them more and more each time that they come, higher level, increase the volume of the exercise, and progressively overload these clients. There's so much more that I would love to cover about diastasis recti. We're really short on time. I went definitely over time here, but if you guys have any questions at all, feel free to shoot me a message. I'm at Kelsey Valentine PT on Instagram, or you can contact me through here. And also remember that our course, Clinical Management of the Fitness Athlete, Pregnancy and Postpartum, begins on September 14th, 2020. So thank you guys so much for listening. This was a lot of fun. And again, any questions, send them my way.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.